you can get fairly significant bleeding from fractured surfaces, particularly the iliac wing and iliac bones. And then finally, you can get arterial bleeding. So this may be from superior gluteal artery if they get fractures near the sciatic notch, from the corona mortis, if you have heard of that, which is a communication between the obturator artery and the external iliac, or the external iliac artery in some cases. Now the posterior venous plexus is extremely fragile, and as you might imagine, it's fairly prone to bleeding if you damage structures around the sacrum, and particularly the anterior sacroiliac ligaments. And once as with any venous bleeding, it's very difficult to control, other than with sort of with significant tamponade. It will settle down eventually, as long as there is some tamponade effect. So usually when the clot forms, they will start to return to some sort of hemodynamic stability with the venous bleeding. So the most important thing is really understanding the injury and what structures might be causing issues. There are various ways of classifying it. The first and most commonly used now is probably the Young and Burgess system, which really classifies the injury as to how it's happened. So is this an anterior posterior compression force? Is it a lateral compression force? Or is it a vertical shear type injury? So the anterior posterior compression is classically seen on the motorbike, or motorbike riders, where they hit the fuel tank and they get that spreading, the spread leg type effect, and you get this direct anterior impact, which, as you might imagine, causes spreading of the symphysis pubis and all the structures are sequentially behind. They're graded into 3 grades. So the APCI is where the stronger ligaments at the back of the pelvis, the anterior sacroiliac and the vertebral pelvic ligaments are still intact. The symphysis pubis is disrupted. The APCI is where you get a slight springing open. So those anterior ligaments of the posterior group. So the anterior sacroiliac ligaments are disrupted as well, but the very strong posterior sacroiliac ligaments stay intact. So you get what we typically see as the open book type fracture. And then finally, the APCI is where the posterior sacroiliac ligaments go as well. And then you get something more akin to a vertical shear injury, where there's no inherent stability to one of the hemipelvises. Okay, moving on to lateral compression injuries. So this is the side-on impact. So less commonly, you'd get a bull charging into a matador, but more commonly you'd get the driver or passenger in a car getting the side impact, and the whole of the side of the car drives in. And you get the battering ram effect of the femur coming in and driving the rest of the pelvis into the viscera inside. So you get an internal rotation effect at the iliac crest. Quite commonly, you'll see a sacral impaction fracture. And the ramus fracture tends to be quite, if you're looking in the axial plane on a CT scan, it tends to look fairly horizontal. And that's sort of a key giveaway in terms of what the mechanism of injury might be. And these are the types. Again, there are 3 types in the Young and Burgess system. So the LC1, which is the top left corner, you'll see that the ramus is fractured and you get the buckling type effect in the sacrum. In the LC2 fracture, you get more of a complete fracture at the back. And again, typically it's described as a crescent fracture, where the fracture might exit through the posterior aspects of the ilium and through the sacroiliac joint. And then the LC3 fracture is where you get essentially an LC2 fracture combined with an anterior posterior compression type fracture on the other side, which is essentially the force continuing through to the second hemipelvis, or the contralateral hemipelvis. And the vertical shear really is a combination of everything, where there's both rotational and vertical instability. So essentially all the ligaments that support the pelvis are gone, and there isn't any sort of inherent stability left in any plane. So how do we manage hemodynamic instability that's associated with pelvic ring injuries? Well, the first thing is essentially to follow the ATLS protocol. So we have to resuscitate the patient, we might correct any blood loss, we have to diagnose whether or not it's truly the pelvic ring injury, because to break a pelvis, it's very likely that you have other injuries because the force taken is fairly huge. And then we have to stabilize them. So we have to somehow turn off the tap, stop the bleeding. So in terms of the resuscitation phase, although ATLS teaches crystalloids and walking along with Hartmann's or Ringer's lactate or whatever, certainly Ringer's lactate when I went through it, there's actually very little point in giving someone who's massively bleeding lots of crystalloid solution. The mainstay of resuscitation should be blood and blood products. So most massive transfusion protocols nowadays will be activated before the patient even lands in your ED. And they usually give a ratio of 1:1:1 of red blood cells, FFP, and platelets. Now, one little rider with that is normally in this country we pack platelets in units of 4, so it's 4:4:1 really in terms of platelets that you'll get given. As I mentioned, you have to avoid overuse of crystalloids. They've lost blood, they haven't lost fluid, and liaise very early on with your hematologist. They have lots of fancy ways of detecting which bits of blood are necessary, which particular blood products might be useful. So TEG scans and ROTEM scans are particularly useful now, and you can direct your blood and blood products at particular problems. One thing to remember, I suppose, is that checking the hemoglobin is pretty useless in this situation. You're much better relying on your clinical indicators of shock, because the blood that's out on the floor or the blood that's in the pelvis is going to have the same concentration of hemoglobin as the blood that you take from the vein. So hemoglobin falls and rises are very poor indicators of blood loss in the acute situation. One thing not to forget, tranexamic acid. It's an antifibrinolytic drug which inhibits both plasmin and plasminogen, and they should ideally have a 1 gram bolus within 3 hours of the injury. So very commonly they will get this on, they'll get their first dose with the paramedic team that's scooping them up. Very commonly the second dose is admitted because you are meant to have a second dose of 1 gram either in the first 24 hours or over 24 hours. So it's an important one not to forget. It's a very cheap, very reliable, very good drug with very little in the way of side effects and can be life-saving. The next bit is the diagnosis bit. And really the mainstay of diagnosis now is a trauma CT. Gone are the days where you used to try and spring a pelvis and assess whether it was unstable, or do lots of fancy clinical or radiological tests, or even the initial AP pelvis. Most CT scanners and MTCs are located very close to the ED department, so you can essentially wheel through the CT very quickly, or as quickly as you might otherwise. And if they're not stable enough for the CT scanner, they're very, very unlikely to do particularly well. So ideally, they want to be wheeled through that CT scanner within 30 minutes of arrival to the hospital, and that will allow you to assess the stability of the injury and the type of injury it is, which will hopefully give you a clue as to whether or not the pelvis is the cause of bleeding, and if so, which bit of the pelvis might be responsible for the bleeding. We'll come back to that. A contrast CT will allow assessment of the vasculature at this stage, which is again fairly important. And again, you might see arterial bleeding or venous bleeding. But the other thing that the trauma CT will allow you to do is diagnose where else they might be bleeding from, because it can be very easy to get caught up in the fact they have a pelvic fracture and therefore that's the only injury. Whereas once you know that they have a chest injury or abdominal injury, it may be the pelvic fracture is the least of your concerns. So how do you stabilize the bleeding? Well, the mainstay now really is the pelvic binder, and that's been our one device that's changed the management of these patients massively in recent history. The pelvic binder can be a very simple device. It can just be as simple as tying a sheet firmly around the patient. But equally now we see the very fancy pelvic binders that clip on, clip off, and get tied in. External fixators we'll talk a bit about. A C-clamp I'll take you through a little bit, and we'll also talk a little bit about pelvic packing and interventional radiology and where they might come in. So going back to the pelvic binder, again, the classical method and for the older amongst you like myself, you might well have put a sheet on and just twisted it and tied it. The important things to remember are try and internally rotate the knees and put a sling around the knees, sorry, internally rotate the legs and put a sling around the knees, and that will just help to reduce the pelvis. And the binder really needs to be at the level of the greater trochanter's, because what you're trying to do is use the femurs, or the head of the femur, to push against both sides of the both sides of the pelvis and produce that compression in the pelvis. And what you're trying to achieve is really pelvic stability. You're not trying to reduce fractures. You're not necessarily trying to get things anatomical, but you are trying to, or even as some have previously said, to reduce the pelvic volume. All you're trying to do is achieve a stable base for that blood clot to form. And as soon as this blood clot forms, your patient will become much more stable. So what are the complications of binders, and why aren't they useful to keep on for long periods? Well, skin necrosis can occur fairly quickly, and that's been reported as early as 4 hours after application. And they should really not stay on for no more than 24 hours, mainly because in that time you should have come up with a plan for them, so that's something that's more definitive than the binder. And in that time, they should have formed that clot. The other main issue with binders is that they can sometimes reduce the injury so well, particularly if you have the APCI type of injury where it hinges at the back and you squeeze it down and it closes at the front, that they reduce the fracture so well that you miss the injury on the CT scan. I've had a number of patients who've come through and only with a diagnosis 3, 4, even 5, 6 weeks after their initial trauma, and then it's a much more difficult problem to deal with. So if they've come in with a binder on and you don't see and you can't diagnose the injury to start with, they should always have a pelvic X-ray outside of the binder. And certainly in the MTCI workup, we've made that mandatory that if they come in with a binder on, they should have a view with a binder off before they rule out a pelvic ring injury. External fixation. So we've probably gone away from the emergency external fixator fairly dramatically in the last few years, and there are very limited circumstances where you might use it. So the first is where they have persistent hemodynamic instability when the binder is removed. Now again, that's probably only in conjunction with other things that you might do, because really if they're unstable with a binder on, they're likely to be unstable with an external fixator on. I don't think it will give you any more stability than a well-applied binder. The other situation is if people are performing laparotomies, then they may well wish to have some sort of temporary pelvic stability, in which case it's perfectly reasonable to put an external fixator on, because the binder is more than likely to get in their surgical field. And finally, if you are undertaking pelvic packing or surgical pelvic packing, again, which we'll come to in a minute, you're almost obliged to put an external fixator on, because if you don't, you can essentially pack and pack and pack and expand the pelvis and expand the pelvis and keep going. Whereas if you put an external fixator on, you have a stable pelvis which to put these packs into and create more of a tamponade effect. So this is an example of one. So traditionally, certainly the teaching, probably because it's easier for most people, is that you have 3 pins in the iliac crest. I think certainly in most centres that are doing pelvic surgery, we now prefer to use supraacetabular pins, because they will give you a much better purchase in the bone. You can use less pins, and they tend to be more secure and stable if you do use it definitively at any stage. They're ideal for the anterior posterior compression type of injury, because you can put the pins in and squeeze the pelvis back together. They can be permanent, although certainly if you have disruption through the symphysis, it's probably not as good as definitive fixation. And they can be used in combination with other temporizing measures, such as a skeletal traction pin in the femur or in the proximal tibia, in the vertical shear type pattern. Something to remember in terms of the vertical shear is that if you put an external fixator on, you don't really have anything that you can stabilize with particularly easily, because remember, all those ligaments are gone. So you still have that floating pelvis, which is why the traction pin comes in useful. Complications of external fixators. So the first, again, is that skin and soft tissue necrosis. And it's very typical because when you put the pins in and then you squeeze it down, the skin is quite often not adequately released, because your entry point might be 2-3 centimeters away from where your pins will end up once the pelvis is actually reduced. And so quite quickly you'll see these sort of necrotic lesions form around the pin sites, generally because of pressure necrosis. And the second picture you see on the right is essentially the main issue with the iliac crest pins, in that it's very easy to miss with them. It's very easy to miss with them, and it's also very easy to go get out very early, so you don't get a very strong hold in bone. The ilium at the point that you're putting those pelvic pins in the iliac crest is pretty thin, and part of the reason why people put 3 pins in is because you're more than likely to miss with 1, if not 2, of those pins. So a C-clamp, again, this isn't really something that's used very often now, mainly because it's so dangerous to use without knowing exactly what you're doing. And essentially what you're trying to achieve is putting the C-clamp in the same sort of channels that you might put your sacroiliac fixation in, and that sort of area, where again, if you're not used to that, the anatomy around there, it's very easy to hit major blood vessels. And indeed, there have been people that where sort of more harm has been caused by the C-clamp than any good. So this is something that most units have probably gone away from, but it will close down the type C fractures, and it will provide you more stability for a vertical shear type fracture than just the anterior X-fix will. And this is just showing where you're meant to place it. Okay, I mentioned pelvic packing earlier. So this, in terms of surgery, is extremely useful. It's a useful skill to be able to perform. The key to pelvic packing is that it is extraperitoneal. It is essentially, the way of doing it is essentially to get in to the retropubic space, and if you're having to do this as a procedure, once you get into there, you will essentially get it and unleash a torrent of blood, which will come out because that's where the patient's bleeding from, and you'll be able to follow that, track that back all the way to the SI joint, which is where that venous plexus is that we talked about right at the start, and that's where the bleeding is from. And essentially, you're trying to push your packs all the way around the pelvic brim to where that SI joint is, and you'll lay all those packs in, and you'll leave them there for 2 days or so, and go back and take them out, and hopefully then definitively fix the pelvis. And last of all comes angiography and embolization, and it's very easy to jump to this before you've done all the other things, but it's also probably the least likely thing to give you to stabilize the patient. Of all the interventions we've talked about, probably the pelvic binder is the most useful, and will be the most useful for the biggest number of patients. Angiography and embolization is useful if you can find a named artery that they're bleeding from, and even then it's probably a named small vessel such as the superior gluteal artery or the internal iliac, or the obturator that they're bleeding from. Some of the bigger vessels either are too big to gain useful embolization, and some of the smaller vessels probably are not worth embolizing. So the main indication is localized arterial bleeding that they see on a CT angio from a named vessel in a patient that is a transient responder. So that means that they respond to the blood and the major hemorrhage protocol that you might institute, and they get some benefit from it, but immediately, fairly quickly afterwards, they again relapse into a shock type situation and hemodynamic instability. So that along with your CT angio will give you an idea as to whether or not angiography and embolization might work. So briefly about the open pelvic ring injury. So this is really a pelvic ring injury with either an obvious open fracture that communicates, such as you might see around the iliac wing, but also those that might be less easy to spot, such as rectal or vaginal tears. And the real trouble with these is essentially the mortality is so high because they're very, very prone to getting infected, and allowing infection to come in or fairly mucky contents, particularly with rectal injury or vaginal injury, into what is otherwise a sterile area, and normally a sterile area. And the key to managing these is to convince your general surgeon that they need to perform a diverting colostomy fairly early on, as in immediately, within the first few hours of them coming in. And the quicker they can do that, the better their outcome, or the better the patient's mortality will be. And again, you wouldn't be worried about fixing the pelvis necessarily or stabilizing it. The key is much more to do with getting rid of that dirty, mucky contents that might be contaminating, that might contaminate your injured pelvis. Okay, so in terms of principles of managing them acutely, aggressive resuscitation, don't be afraid to get blood and blood products into them quickly. Debride any wounds that might be present. External fixators or skeletal traction we've talked about. And early fixation, if it's easy and possible and part of your damage control process, then do it, but it doesn't have to be done immediately. But the early colostomy might save lives. Okay, and that's been shown previously that you might reduce the mortality by up to 50% if you can do it, if you can do that diverting loop colostomy within 24 hours. And then the debridement and early definitive stabilisation, well, sort of some nice pictures there, but again, that doesn't have to be early. It can be delayed, but it's when it's most appropriate to do so. And you've got to balance the risk of intraoperative infection or early infection when they've just had that open wound. If it's particularly mucky or contaminated, then you may wish to defer it until you go back. But equally, if you can stabilize it, then you might well do better at controlling the bleeding that might happen, or controlling the hemodynamic stability. So in terms of ICU management issues that you might come across, again, it's hemodynamic instability. Visceral injuries are fairly common, and how to manage those. VTE prophylaxis is something to really consider fairly early, because pelvic ring injuries might produce, or do produce, a 15-fold increased risk of VTE, and it's even, and more significantly, a fairly significantly higher risk of PE, or life-threatening PE. And early movement, again, is key. So the pelvic ring injury should not really stop you allowing them to get moving, rolling, and whatever else they need for managing that patient. Again, just a quick recap: if they're hemodynamically unstable longer term, they're either underfilled, they may have lost a lot of blood initially through whatever injuries they had. They may be unstable, or they may be a transient responder, and it's working out which of those you need to deal with. Visceral injuries that can happen and that you might need to assess: urethral injuries, bladder injuries, and bowel injuries. And these are all more common with the lateral compression type injuries, because if you imagine the anterior posterior compression, you're opening out the pelvis and almost creating more space for those organs, whereas the lateral compression, you're compressing everything in, and you're driving those bone spikes into those organs and blood vessels. Sorry, I mentioned VTE prophylaxis already. And again, movement. So although I mentioned early movement, you do need to allow that clot to form. So in that first 24 hours, keep them stable, keep them still, and allow that clot to form. Once that forms, usually they will be good enough to be less worried about until you can get them into surgery. And finally, late management in terms of pelvic ring. We've mentioned pin site care with external fixators. Weight-bearing status can be difficult sometimes, and the thing to remember with weight-bearing status is it's probably the injury at the back that determines whether or not you're happy to weight bear them. So if the posterior part of the pelvic ring is stable, then I'd be much happier to allow them to weight bear on that side. Whereas if the posterior part is unstable or tenuously fixed, then you have to go a little bit easier. Beware bowel and bladder dysfunction, even though that may not be directly damaged. Some of the nerves that supply either might be affected. Sexual dysfunction is fairly common and less commonly talked about, but it is an important issue for most patients that come through. And there are significant psychological sequelae to both the injury, the trauma, and the potential sequelae that might come about And most trauma centres now have a psychologist that's attached to them to help manage those. So in summary, these are potentially life-threatening injuries. There are a variety of different strategies that you may wish to use and employ early on in the acute phase. And in terms of the definitive management, really you're looking at using specialized units and trauma centers. The early diagnosis and treatment is essential, and understanding the injury is really useful. And again, going back to involve the specialist teams early. Most people, or most centers now have some form of on-call system for pelvic trauma that people can ring up about and ask questions, if not, to get on-site help. Thank you. I think that's me.
Thanks, Amal. That was great. So, Nicole, were any questions that you want to discuss with Amal?
No, I think I've answered most of them in a non-controversial manner.
Good man.
Amal, there was one question that was asked. Would you prophylactically consider embolization of something if you don't find a source of bleeding?
So personally, I'd say absolutely not, because you've got to remember that the embolization, the artery that you're embolizing is supplying something useful. So for example, I did spot that one of my esteemed radiology colleagues was part of this as well, but most interventional radiologists, when they perform the interventional radiology, will find something to embolize. Now, for example, there have been a number of instances where they might embolize the internal iliac because they can't, they think that something's bleeding and they're there, they might as well do it. But again, if you're then going to go in and say fix a posterior wall fracture, you're then going through potentially devitalized gluteal muscle, or which will create a much bigger problem. So I would say if you can't find a named vessel that it's bleeding from, avoid embolization.
That's great. Thanks. Well, and I'm sorry to everyone, you can't see all our faces. There was just something in the setup that I forgot to click, and for me to go back into the sort of the mechanics of it, it might actually put us all off air, and there's quite a few participants watching this, so I just don't want anything to derail the evening. So Michael, do you want to now talk on fractures of the acetabulum?
Can you see the presentation?
Yeah.
And can you hear me?
I can hear you and see it. Thank you.
Okay, great. Right, good evening, everyone. Thank you for sparing a Sunday to come and listen to us. So I'll try and stick to my time, and we'll cover, it's a big topic to talk in one lecture, but we'll try and cover it under these headings. So these are difficult fractures, and we know that the acetabulum has a very complex anatomy that a lot of us don't fully understand and appreciate. It has a long learning curve to try and learn it properly. Usually acetabulum fractures come as isolated injuries, but a significant proportion can be associated with polytrauma, and so the management will depend upon other soft tissue systemic injuries or long bone injuries. If you look at the historical literature, elderly patients have traditionally been treated without surgery with good outcomes, and younger patients, when they were treated without surgery, sometimes did not have good outcomes. But it was like comparing apples with oranges. What Letournel showed is that these are intra-articular injuries, and when you aim to try and get an anatomic reduction, you can get a 90% good result in short to medium term. But if you have persistent incongruity, then about half of them will do quite badly and develop secondary post-traumatic arthritis. The commonest mechanism is high velocity accidents, injuries when you're the driver or passenger of a car, pedestrians. Motorcyclists and cyclists seem to be very common at the moment in summer, and falls from height. A growing epidemic is elderly patients with osteoporotic bone fall from a standing height, usually on the side, and the acetabulum literally implodes from inside. Very difficult comminuted shattered fractures. And what we see at Wrightington Hospital, because our practice is not just pelvic and acetabular trauma, but all forms of complex hip, pelvic and acetabular surgery, is we inherit a fair number of acute periprosthetic fractures of the acetabulum and chronic pelvic discontinuity, where you can apply the same principles. The exact type of fracture will depend upon how the force is applied, how much force is applied, and the position of the leg when that force is applied. So whether the hip joint is flexed or extended, adducted or abducted or rotated. So if your hip joint is flexed, like you're a driver, and the force comes from the knee into the femur, you're likely to have a posterior wall or a posterior column fracture with a dislocated hip. I'm sure that all of you have heard about or read about the Y-shaped acetabular anatomy concept. So Letournel described this concept, which looks quite like the Eiffel Tower. You have an anterior column, which goes from the anterior part of the iliac crest down the iliopectineal eminence all the way to the pubic symphysis. And then you have a posterior column that involves the posterior buttress of the ilium, the greater sciatic notch, down the way to the ischium. These two inverted arms of the Y support the acetabulum, and it has its weight-bearing dome where the columns join. What is important is that we don't forget the soft tissue anatomy of the acetabulum. Particularly posterior to the hip joint, you have your sciatic nerve and the superior gluteal neurovascular bundle. And in the anterior aspect, you have the iliofemoral vascular bundle and the branches of the external and the internal iliac artery, which can be at risk during the injury or during surgery. And it's very important to know where these blood vessels are, particularly the corona mortis, which, like Amol mentioned, is an anastomotic branch, usually between the obturator and the inferior epigastric branch of the external iliac. When I started doing acetabular surgery through an ilioinguinal approach, I never saw this blood vessel, so I believed it never exists. When I started doing the stopper approach, almost in every patient, you can find it. If you want to take one learning point away from today's talk, it is the analysis of X-rays of the pelvis and the acetabulum. So if you look at an AP pelvis, please have a system of analyzing the X-ray. Divide your X-ray into zones if you want to. The sacrum, the lumbosacral junction, each iliac wing, the hip joint, the acetabulum, and the lower part of the obturator foramen and the ischium, and then work systematically. And as far as the acetabulum fractures are concerned, try and draw these 4 lines: the iliopectineal line, ilioischial line, and the lines which represent the anterior and the posterior wall. These are visible on an AP pelvis, and what happens is they are condensations of bone. So when the X-ray beam passes through the pelvis, these appear as the lines. What Letournel again explained to us is that the iliopectineal line represents the anterior column of the acetabulum, and the ilioischial line represents the posterior column. So if these lines are intact, the columns are likely to be intact. If the lines are broken, that column is fractured. Then you have the lines that represent the anterior wall, which tends to be more medial and incomplete, and the posterior wall, which tends to be more lateral and complete. And then you will be familiar with the sourcil or the dome of the acetabulum and the teardrop as part of your learning from hip replacements. So let's do a quick, well, this was meant to be an interactive slide in a face-to-face talk. So this is an X-ray of the pelvis. You can see that on the right side, the iliopectineal line is broken, but the ilioischial line appears to be intact. So what you can say from looking just at an AP X-ray is, in the very least, the anterior column is fractured, but then you want more views to look at whether there are any other injuries. Another X-ray where you can see that the iliopectineal line and the ilioischial line are both broken, and plus there are fracture lines that go through the iliac wing and through the conjoint ischiopubic ramus. So what you can say is that the anterior and the posterior columns are both fractured on this X-ray. If you start looking systematically at AP X-rays, slowly you will be able to diagnose the vast majority of fractures on simple X-rays, and then CT scans can be additionally helpful. Jude views I still find very helpful in decision making when they are available, but nowadays with trauma CT protocols and 3D reformatting, we rarely obtain Jude views. To obtain an internal oblique Jude view, the patient has to be turned to 45 degrees and the obturator foramen comes into view. So this is very good for seeing the anterior column and the posterior wall. So this is an X-ray of an internal oblique Jude view of the left acetabulum. And correspondingly, you will see that the right acetabulum gives you an external oblique Jude view. So it's important to include both hip joints when you obtain Jude views. This is the external oblique Jude view, where the patient is then turned to the other side by 45 degrees, and you can see the iliac wing in profile. This is good for the posterior column and for the anterior wall. So this is the other Jude view. Again, you can see that the opposite hip gives you the opposite Jude view, and it's very useful for comparison. CT scans are almost invariably obtained for acetabulum fractures. The picture on the left side shows the anterior wall and the posterior wall, and you can see the direction of the fracture line represented by the yellow arrow and then by the red arrow. So if the arrow is going in the anterior posterior direction on an axial image, it usually means that it's a wall fracture. On the image on the right side, on the upper part of the screen, you can see a yellow arrow that represents the anterior wall fracture, and then a green arrow that shows you the anterior column fracture. So again, look at the fracture line. When it goes in the AP plane in an axial CT, it's a wall fracture. And when it goes in the mediolateral plane or the coronal plane, then that's a column fracture. And in the lower part of the right side, you will see what is called as marginal impaction. All of you have heard of a depressed tibial plateau fracture. So a marginal impaction is a similar lesion where a piece of the articular cartilage and the cancellous bone gets impacted into the cancellous bone of the posterior column. This is a poor prognostic injury, and it has to be identified and accurately reduced. Otherwise, the risk of arthritis is very high. And 3D reconstructions really help you to plan your injury and your approach and the surgery. Most of you will find classifications quite boring, but of all the classifications that are available in orthopedics, if there is one classification that helps me with planning treatment and understanding the anatomy, it is the Letournel classification. In my biased opinion, probably the best and the most useful classification in trauma. So what Letournel described is two groups. The elementary types have got one main fracture line, and the associated or the complex types have got more than one predominant fracture lines. So in the elementary types, we have the posterior wall or the posterior column fracture, the anterior wall and the anterior column, and we have the transverse type. In the associated or in the complex type fractures, we have combinations of these. So you have posterior column with wall, transverse with posterior wall, a T type, an anterior column with posterior hemitransverse, and the associated both column type. You also have the AO classification, which is a type A is partial articular with one column involvement, both column involvements, and a type C is a complete articular. I don't really find this classification very useful to plan treatment. The main use for these classifications is to determine the direction of displacement of the main fragment, because that is going to guide your approach. If most of the fracture is displaced posteriorly, you're going to use a posterior approach. And if it's displaced anteriorly, then you're going to go in from the anterior side. And this is my favorite classification of almost everything in orthopedics. The good, the bad, and the ugly. Always works, internally and externally validated, and very, very consistent. So let's look at some pictures representing these classification types. These have been taken from Marvin Tile's book, and they're very useful to understand the anatomy. The first one shows you a posterior wall fracture, typically associated with a hip dislocation. It can be one large fragment or comminuted, and you can see on an axial CT how the fracture line comes out at the back and the hip joint is unstable. You have to look for marginal impaction in these injuries because it determines the prognosis. This is the posterior column fracture where the wall is intact, but you can see that the fracture line goes through the posterior column and exits through the obturator foramen and the conjoint ramus. Anterior wall and anterior column. An anterior column fracture can be a low fracture or a high fracture. Then you have the transverse type where the fracture goes across the acetabulum, and this can be infratectal, juxta, or transtectal depending on whether the fracture goes through the weight-bearing dome or below that. Naturally, the transtectal fracture which goes through the weight-bearing dome has got the worst prognosis. That's how a transverse fracture looks on a CT scan. The fracture line goes from anterior to posterior, because the CT is taken in an axial plane. So these are then the complex type or the associated types. You have your posterior column with wall fracture, a transverse fracture with a posterior wall, a T-type fracture, which is basically a transverse fracture, but there is another fracture line going like the arm of a T and exiting through the obturator foramen. So when you look at a transverse fracture, always look at the conjoint ramus. And if you see a fracture line going through that, then you know that this is a T-type fracture. The important part of a T-type fracture is that some part of the weight-bearing dome of the acetabulum is still attached to the intact ilium. And the importance is that if you don't appreciate it's a T-type fracture and reduce one component from a single approach, you might not be able to reduce the other component. And for accurate anatomic reduction, you have to appreciate and reduce both components correctly and fix them. This is an anterior column with posterior hemitransverse, which you can see is a variation on the T fracture theme. And then this is a both column fracture, where both your columns are fractured and the entire hip joint will be displaced medially and internally. Now, the main difference between a T-type and a both column fracture is this. In a T-type, some part of the acetabulum is still attached to the intact ilium. And in an associated both column, none of them is. Now, I've covered the classification in some detail, but I suspect that for the FRCS orth, you will not need to know the classification in detail. And I don't think you will be able to, or you will be asked to identify a fracture on an X-ray. The most likely possibilities that you will be shown the X-ray of an acetabulum fracture. Most likely it will be a posterior fracture dislocation, which you should be able to diagnose fairly easily. But if you start practicing this methodical approach of drawing the lines, and in an exam scenario, even if you can draw the lines correctly and give the interpretation correctly, I'm sure your examiner will be fairly happy with that. Okay, so let's look at the principles of management. Amol has already covered the ATLS protocols for polytrauma, so I won't go into that. Restricted to the acetabulum, in casualty, look for deformity. If the hip joint is dislocated, your leg is going to be either adducted and internally rotated in a posterior dislocation, or abducted and externally rotated in an anterior inferior dislocation. Look for other injuries, particularly femoral fractures. Anyone knows what that is? A soft tissue degloving type injury on the side of the right thigh. That is called a Morel-Laval lesion, which is an internal degloving injury. It's a warning sign of very significant soft tissue injury. And if you cut through that or make your incision through that, you're likely to end up with infection or skin necrosis. Make sure that you look for injuries to the blood vessels and the sciatic nerve. 20% of posterior wall fractures can be associated with a sciatic nerve injury. And make sure that you document the sciatic nerve function by checking ankle dorsiflexion and toe dorsiflexion, where possible, of course, in a conscious patient, frequently, and make sure that every time it is documented. Then you go for imaging, X-rays and CT scans, and we have seen how they look. All fractures of the acetabulum don't necessarily need surgery. There is still a role for non-operative treatment, even in modern orthopedics. If your weight-bearing dome is intact, if your hip joint is congruent in all the views, if the hip joint is stable and there is no evidence of subluxation, you can treat the fracture conservatively. The advantage is you avoid surgery and all the iatrogenic and the surgical complications. The disadvantage can be sometimes the disadvantage of recumbency, lying in bed for a few days or sometimes a few weeks. If the patient is very elderly, unfit, multiple medical comorbidities, very comminuted fracture, and very poor bone quality, where fixation is hazardous, you would try and treat that conservatively. And finally, if the fracture is unfixable, but it may be unfixable in your hands, someone else might be able to fix it properly. So that is a relative contraindication to surgery, or a relative indication for conservative treatment. This is something called secondary congruence, which was described by Letournel. This is an associated both column fracture where the whole acetabulum drives medially into the pelvis, but both the columns stay together. So the congruency of the hip joint is maintained. Okay, and this has a good outcome after healing. And we have several of these elderly patients who come back to our clinic with good secondary congruence, and they go on for years and years without any secondary arthritis. The methods for non-operative treatment, traditionally, we used to use skeletal traction and keep the patient in bed for 4 to 6 weeks. Nowadays, the role of traction for 4 to 6 weeks is very rare. We believe in early mobilization for most of these cases. There are certain advantages for temporary traction because it keeps the head away from sharp fracture fragments. If we are treating fractures conservatively now, generally speaking, we will give them some bed rest till the pain improves, usually a few days, with good aggressive pain management, chest physiotherapy, sitting up in bed, passive physiotherapy in bed for the leg, and then weight bearing as able. In older patients, it is very difficult to tell them to be non-weight bearing. So by and large, they will weight bear as able, and majority of them will be fully weight bearing. It's quite rare to see a displacement. Lateral traction used to be used in the good old days. It is not recommended, high risk of infection, and it does interfere with future approaches. So please don't discount conservative treatment of acetabulum fractures. Sometimes you have to treat conservatively because the referral is delayed or the patient is unfit for surgery. Some of these may get arthritis later on, and you may have to convert them into a total hip replacement. And it's not such a difficult job to do, even if you do have to do a total hip replacement. If you look at literature for all conservatively treated fractures of the acetabulum, the chances that you might need a total hip replacement later on is between 6 and 14%. And if you look at mortality figures in elderly patients, quite counterintuitively, the mortality of conservative treatment is not worse than surgical treatment. In some series, it is actually better. Operative treatment, young patient, intra-articular fracture which is displaced, involves the weight-bearing dome. Instability. Obvious instability will be a hip is dislocated, but sometimes you have occult instability, which might only be picked up in theater with an examination under anesthesia. And incongruity, where the fracture fragments have an obvious step. You can sometimes live with a gap, but you can't live with a step. A step usually causes arthritis quite early on. This happens in displaced fractures, and you might get incongruity because of intra-articular fragments, soft tissue interposition, and once or twice I've even seen the sciatic nerve interposed in an acetabulum fracture, preventing relocation of the hip. Irreducible fracture dislocations we will discuss in detail later on. And in some elderly patients, there is a vogue now to try and aggressively operate on them to try and get them up sooner rather than later. So the indications for fractures in elderly for surgery could be that you operate on them and just fix them to try and facilitate a total hip later on, or you do both at the same time. And we'll see an example later on. Emergency open reduction. I think I've only had to do one emergency open reduction of an acetabulum fracture, and this was in an open fracture. Generally, open fractures tend to be associated with pelvic ring injuries. Vascular injury could be an indication if the vascular surgeon strongly feels that the hip joint is so unstable that it is going to compromise the vascular repair. But nowadays, with interventional and endoscopic vascular surgery, that is really not an indication for emergency ORIF of the acetabulum. The acetabulum ORIFs tend to be difficult. They need a lot of preoperative planning. You need a full team, correct kit. And this is a type of surgery that I don't really want to start in the middle of the night. I want to do it on a proper planned pelvic list with everything that I need to hand with all the staff that is correct. If you get a sciatic nerve injury after a manipulation of a dislocation, again, this is a relative indication. And it does depend on which hospital you're working in and whether you have a pelvic surgeon available on standby. So the principles before you start surgery is make sure that the patient is appropriately resuscitated and correctly worked up for major surgery. These operations can take long. Some of the associated both column fractures can take up to 3-4 hours. If you have to do an anterior and a posterior approach simultaneously, it might take all day. Prophylactic antibiotics are used. Routine use of cell salvage and tranexamic acid. Important to use DVT prophylaxis correctly, and then prevention of heterotopic ossification. DVT prophylaxis does come as an exam question very frequently. Our protocol is Fragmin or any low molecular weight heparin for about 6 weeks. Our older protocol was warfarin for 3 months. Some units in America still use warfarin for up to 3 months. But there are various protocols. Again, if you read the BOST guidelines, most of the things are covered in that. And then indomethacin for heterotopic ossification prevention. The role of indomethacin or radiation is debatable, and the efficacy is also debatable. Some units use it, some units don't use it. Timing of surgery. Generally speaking, if you have a simple type fracture, the traditional recommendations were that you try and get them operated within 2 weeks, and you can still get a good reduction. But if it's an associated type fracture, you try and get them within 5 days. In the modern world, if you are working in a major trauma center and you have 1 or 2 pelvic lifts every week, it is quite likely that you will get all of them operated within 3 to 5 days. If you work in a center where there is no pelvic surgeon and you have to transfer the patient out, then sometimes there might be a little bit of a delay of 5 to 7 days. These are the surgical approaches that we commonly use. The top 2 approaches, the Cockle-Langenbach and the ilioinguinal or the stopper, are the workhorse. And 95% of the times they are sufficient to reduce the fracture correctly. When Letournel did all this work, he used to get the fractures quite late, 3 weeks, 5 weeks. So he described extensile approaches or combined approaches for pelvic and acetabular surgery because he wanted to try and get accurate reduction. But they do have a higher morbidity, infection, bleeding, and heterotopic ossification. A Cockle-Langenbach approach is the workhorse for all posterior acetabulum fractures. The key is to make sure that you identify the sciatic nerve. There is a difference in how you handle the capsule of the hip joint as compared to a hip replacement approach. So a lot of people feel that they have done a posterior hip replacement and they can do a Cockle-Langenbach, maybe, but there are certain differences that you need to appreciate. You can add a trochanteric osteotomy, conventional, or the Gans type, and a safe surgical dislocation to help with the reduction through a Cockle-Langenbach approach. The workhorse on which I trained 15 years ago for anterior surgery is the ilioinguinal approach. I got asked this in the exam, so I think it is an exam question. But the principle is that you work through 3 windows. The development of the windows hinges on identifying the iliopectineal fascia. This is the key to performing the approach. I would strongly suggest that you read your anatomy around this area properly because it does crop up in an exam. Questions on anatomy are very frequent. As you get more and more experienced, you start using the stopper approach with or without the first window of the ilioinguinal, and many fractures for which an ilioinguinal was necessary can now be done through a stopper approach. Again, the key in a stopper or an anterior intrapelvic approach is the identification of the corona mortis. The iliofemoral or the Smith-Peterson is also very useful in high anterior column fractures where you don't need to go medially. The extensile approaches are hardly ever used nowadays, but they were used for delayed presentations and complex fracture patterns. Percutaneous fixation seems to be the vogue nowadays, even for undisplaced fractures that Amol and I would probably treat conservatively. They do have some role when you're doing an open reduction as an adjunctive fixation. Some people would argue that elderly patients with undisplaced fractures need a percutaneous screw every time so that they can get up sooner. The argument is that the pain levels are better, but if you look at good studies, all these arguments are really superfluous. And if the fracture is undisplaced in an elderly patient, you can mobilize them as able without putting a screw in it. The key is that the fracture should be reducible or reduced. The screw will not reduce the fracture on its own. It does need imaging and it needs experience to do. So let's look at some cases. This is likely to be the most common case that you will be asked in an exam scenario. This is typically a driver of a car, a front head-on collision, and the hip joint dislocates with a fracture of the posterior superior wall of the acetabulum. When he comes to casualty, what would you do? So after your ATLS protocol, you would assess the sciatic nerve, check for foot drop, document it, do a vascular assessment. Then look at your x-rays. The main reason you want to study the x-ray is also to exclude a fracture of the femoral neck and also check whether you have a fracture of the femoral shaft. Then you have to try and do an early closed reduction in theater as soon as possible. This in the UK is generally performed in the operation theater with good anesthesia and good muscle relaxation. In some units in America and Germany, they have the ability to give a proper GA, a deep GA with relaxation in the ER. And in those scenarios, you may be able to do a closed reduction in the emergency department itself. But generally speaking, you do it in the operation theater and you need some experience in reducing the hip joint properly. Traction is given in line with the deformity. There are some named maneuvers described to reduce it, like the Ellis maneuver, or the Bigelow maneuver, which I'm sure you can read up. And you hear the typical audible or the palpable clunk as the hip joint goes in. Then you check your stability by moving the hip around under an image intensifier and check that the hip is stable. And most of the times after you have reduced it, they will get skin traction. Rarely, if the hip joint is very unstable, you might need to give skeletal traction until you have the definitive opinion from a pelvic surgeon. As soon as the reduction is done, make sure that you check your neurovascular function and check that the sciatic nerve is still working after the hip joint has been reduced. Then the patient usually gets a post-reduction CT scan to check for intra-articular fragments, congruency, study the acetabulum fracture, and then it can be sent to a pelvic surgeon to fix it. If you have an irreducible fracture, and I did not know that the Americans actually define what is irreducibility. So an irreducible fracture is one where a senior member of the team fails to get a reduction despite good anesthesia and relaxation. Usual causes: soft tissue interposition, sciatic nerve, or bony fragments. Is it a surgical emergency? Well, that depends on where you are, which hospital you're working in, what is the time of the day, and can you do it safely? If you're going to open the hip joint to reduce it because it's irreducible, can you address all the possible lesions that you will encounter? It is quite detrimental to the patient if you do an open reduction, not address the fracture or the marginal impaction, close the wound, and then the hip joint dislocates again. And then when someone goes in for the second time, the hip gets infected. So in those cases, it is better to phone a friend and transfer this to a specialist unit. And the same applies for unstable or incongruent reductions. So this was our case where a good reduction was obtained in casualty in the operating theater, and then you have a CT scan that shows a posterior wall fracture with marginal impaction, which then are formally open reduced and fixed subsequently with a good outcome at about 5 years. That's probably the most typical question that you will get in the exams. Let's look at some more cases. This is a much more comminuted fracture of the left acetabulum. You can see that the iliopectineal line is broken and displaced, and the ilioischial line appears to be broken but not so displaced. And then the CT scan confirms that the fracture does involve both columns. So this is an associated both column fracture that I fixed through an ilioinguinal first window with a stopper approach from the front to get a good congruent reduction. This is increasing. We see a lot of these acute traumatic periprosthetic fractures, usually 4 to 6 cases in a year from various different hospitals, majority of the times from uncemented components, and you get an acetabulum fracture. So this is where you require the experience of pelvic surgery and revision hip surgery to deal with this. In this case, I've done a reconstruction by fixing the acetabulum using an appropriate uncemented ultraporous socket and an appropriate stem to reconstruct everything in one stage. And this is the 10-year follow-up of this fracture. The elderly fractures are a completely separate topic, and we could have an entire talk on that. But in brief, you can treat them conservatively, which is the vast majority, or percutaneous in some units where they believe that this is the correct philosophy, or the acute fix and replace. Unfortunately, there are no randomized trials to show that one is better than the other, but our experience with big cohorts would suggest that conservative treatment is quite effective, and only a small number of them will come for a total hip replacement. Fix and replace does have its role, especially if your fracture is comminuted and the hip joint is unstable and you cannot get that femoral head underneath the weight-bearing dome. And this is one of the indications where I would consider an acute fix and replace, which is basically you fix the acetabulum and you replace the hip at the same time. It's also called the combined hip procedure or an acute total hip replacement. There are complications associated with acetabulum fractures, particularly with surgery, infection, malreduction, or malpositioned metalwork, intra-articular penetration of the screw into the hip joint, and neurovascular injury. Thromboembolism is a big deal, so these patients do get prophylaxis. And I would encourage you to read a little bit more about thromboembolism because it does come back in the exam as a question quite frequently. Mechanical and chemical prophylaxis is better where possible and where there is no injury to the leg. Late complications are the most common, and they include secondary osteoarthritis or avascular necrosis, and they might go on to developing arthritis, which will need a total hip replacement. Heterotopic ossification of minor degrees is very common. very severe Brooker grade 4 HO is less common. Probably I've seen 2 or 3 cases in the last decade where they developed very severe HO, where the hip became completely ankylosed. And usually that is more commonly associated with severe head injuries. So this is an example of a fracture that was treated conservatively because the patient had multiple other problems. You can see that the acetabulum malunited and developed secondary arthritis, and then a delayed cemented total hip replacement was done using impaction bone grafting, and that shows the 7-year follow-up. Okay, so to summarize what we have discussed in this talk, we have looked at the anatomy of the acetabulum and learned to analyze the X-ray, drawing those lines. I would urge you to work on those lines from tomorrow whenever you see a hip X-ray. If you see hundreds and hundreds of normal X-rays, you will pick up abnormalities very quickly. Understand the classification of acetabulum fractures. These are intra-articular fractures, and therefore, when surgery is performed, an accurate reduction is important, especially in young people. Try and do these through a single approach where possible, because it reduces the complications and gives you a good clinical result. And it's important to involve a specialist as soon as possible. Thank you. Thanks, Mike.
That's great. Oh, that's a great talk. Thank you very much to both of you. Any questions did you pick up there, Amol? Amol, any questions?
Oh, sorry, I was just on mute. No, I think we've answered most of the.
Yeah.
There was minor questions in there that have been answered as we've gone along.
Right. Okay. So for the just to keep to our usual finishing somewhere between 9:15 and 9:30, we'll go straight to the MCQ. As you know, I'm going to launch it now. Unfortunately, those people watching on YouTube Live can't see this, and that's one of the reasons why we don't sometimes go to YouTube Live, but we have done on this occasion because we were requested to do so. So all those 10 questions, all the attendees can now see them and can scroll up and down. Some answer at their own speed, but others like you to read them out. So I'm not sure whose first 5 they are, but if you want to read them out and then give sort of 20 to 30 seconds or so for them to answer it and then move on to the next question, that'd be great. Thanks.
Yeah, Amol, do you want to get going first?
Okay, so the first question we have is, which of the following might be classified within the tile classification as a type A fracture? So we didn't talk through the tile A classification in too much detail, but it's something that you might hopefully have come across. Essentially, A being stable, B being rotationally unstable, and C being unstable. Are we going to the poll after each question, Mike?
Yeah,
or
no, at the end of 10, we go to the poll, we share them, and then we just go back over them again. So nobody's voted yet, so I think people are just sort of waiting till the end. They're probably writing down on a scrap of paper what they're answering on. So if you want to go to number 2, that would be great, I think.
So number 2 is, in a major trauma patient with suspected pelvic ring injury and a high riding prostate on digital rectal examination, the most appropriate next step would be. You have five potential answers there. Okay, question 3 is, fractures of the transverse processes of the lower lumbar spine are typically associated with which of the following? And this is referring to the Young and Burgess classification. Question 4, which of the following fracture patterns is most likely to cause bladder injury? And the final question on pelvic ring injuries was, which of the following fracture patterns is most likely to cause hemodynamic instability?
Short of the two columns. Shall I carry on, Amol?
Yes, I'm through, Nick. Thanks.
Okay, so we'll go on to question 6. In the Letournel concept of acetabular columns, which of the following anatomic structures is not included in the shorter of the two columns? So we'll move on to question 7. Which of the following is not a fracture type in the Letournel classification system of acetabulum fractures? There are 5 options over there. I would rather that you take the time to read them. Okay, moving on to question 8. As related to the radiographic views of the acetabulum and pelvis, the following statement is true. Again, these are big statements. Instead of me reading, it's better that you read them. Okay, going on to question 9. Regarding the corona mortis, the following statement is untrue. I've given you 5 statements. And moving on to the last question. In relation to the Gans surgical dislocation approach, which of the following statements is not true?
Great. Thanks for those questions. They're really quite challenging, actually. 65% of people have voted, so we'll just let that get up to probably 80% or so, because some people obviously don't want to answer the questions. Thanks very much, Amol and Nicole, for doing your great talks. I thought they were fantastic at the right level. It's clearly a really complex problem, but it is something that, you know, a day one orthopedic consultant does need to know about, because, you know, if one comes in on your first night on call, you're going to need to know the principles that you were talking about, and therefore a day one consultant needs to, that's the level of the exams sitting at. Next week, we've got Pediatrics 1, the week after we've got Pediatrics 2, which are obviously really, really big, common, repetitive questions in the exam, particularly on the Viva. Right, we've now got over 75% of people have voted. So what I do is I end the poll and then I just share the results. So perhaps you can see, I was just looking up and down, there's quite spreads really. So obviously challenging questions. So do you want to whiz through them and say why it's the right answer?
Okay, so I'm not me, so I know. So question 1, which of the following might be classified within the tile classification as a type A fracture? So again, like I said, I didn't mention this in the talk, but the tile classification talks about type A being stable fractures. So these are essentially where the pelvic ring is still intact. So all of the fractures that involve either pubic rami or the sacrum won't be stable according to tile. So these are either pull-offs or just fractures that affect the iliac crest or blade. So the correct answer in this case is the unilateral iliac blade fracture.
And can everyone see that 20% of people got that right? You can see that, can you? Okay, do you want to go on to the next question?
Okay, so question 2, in a major trauma patient with suspected pelvic ring injury and high riding prostate on digital rectal examination, the most appropriate next step would be. So this is referring essentially to someone who's got a pelvic ring injury and the high riding prostate indicating potential damage to the urethra. That's really interesting, actually, that you've answered in the way that you have, because there is a whole BOSE document that refers precisely to this, to urological injuries associated with pelvic ring injuries. And the recommendation is that you have a single attempt to pass a standard 14 French catheter. The reason being, and this has been discussed fairly extensively through all the different colleges involved, is that even with a partial urethral tear, you're much better to try and attempt catheterization early once before you move on to more surgical catheterization. So those of you who chose refer to urology, that would be your next port of call, but a single attempt to introduce a standard 14 French catheter is the correct answer. Thanks,
Tom. So these BOSE guidelines, you really do need to sort of know these for the exam. The kind of the standard problems that you all deal with, and obviously, a lot of senior people have put these guidelines together. So I'd really sort of pull all those out and sort of, pore over those in the week before. Would you agree with that, Amol?
Oh, absolutely.
Absolutely. I mean, they're easy cannon fodder for examiners as well. They are, black and white documents that they can pick facts from because there's no argument about them. They are there for everyone should really know. So, I think there are 14 now that there's no reason that you can't just look through them in an evening and know them all.
If I was an examiner and I was going to, ask someone about acetabular fractures or pelvic fractures, that's straight where I'm going to go to the night before the exam. So I agree with you. That's great.
One of the examiners actually mentioned that if you're asked a question which is part of the BOSE guidelines and you can't answer it, it could be deemed to be, well, quite serious.
Yeah.
So like pass-fail questions, really.
Yeah, yeah. I mean, it's a given, isn't it? It's just there.
It is, yeah.
Okay.
So 3 is fractures of the transverse process of the lower lumbar spine are typically associated with which of the following? So historically, it's pathognomonic of a vertical shear fracture. So APCI injury, for those of you who put that down, it's understandable. That is taking all those ligaments and injuring the same sorts of tissues, but like I say, it is associated with the vertical shear more than any of the others.
Okay.
We're moving on to 4.
Yeah.
Okay, so which of the following fracture patterns is most likely to cause bladder injury? And it's pleased to see that we're now into 70% of you getting this right. So LC3 injury is correct. And again, it's that driving in of the compression of the pelvic organs due to the forces coming inwards. And you're much more likely to get those sharp spikes of bone penetrating the viscera with the lateral compression injuries. And LC1 is a relatively stable injury. And again, the LC3 is the highest energy of the lateral compression injury. So the LC3 is the correct answer. And then again, question 5, which of the following fracture patterns are most likely to cause hemodynamic instability? Again, really pleasing to see most of the vast majority of you getting this right. So it's that open book fracture, which essentially produces a tearing of all those veins at the back of the pelvis and in front of the sacrum. And it's once those have torn, that can produce your fairly significant hemodynamic instability fairly early. So that's an APC3 injury is the correct answer for that one. Okay, Nick, I think these are moving on to yours now.
Nicole, are you there? Do you want to?
Yes, I just lost all connections. I'm live again.
Great, come on.
So has Amol finished all 5?
Sorry, yes, you're on to the first of yours, Nick.
Okay. So the first question, in the Letournel concept of acetabular columns, which anatomic structure is not included in the shorter of the 2 columns? So the correct answer is, which is the shorter of the 2 columns? It's the posterior column. So which is the structure that is not included, which is the iliopectineal eminence, which I think 41% of you got correct. This was a simple question really, but you need to know the anatomy of the pelvis to be able to answer these questions. The second one was, which fracture is not included in the Letournel classification? And most of you got it right. It's the posterior column with anterior hemitransverse. So that was not included in the classification. That doesn't mean that the fracture does not exist. I think I've seen at least 2 cases where I've classified it as posterior column with anterior hemitransverse. But the mechanism is quite odd. So most of you got it correct. Well done for that. In relation to the radiographic views of the acetabulum, which statement is true? So again, 43% got it correct. The true statement is that the iliac oblique view is useful to assess the anterior wall and the posterior column. Okay, it's important to understand the Judy views. In relation to the corona mortis, which statement is untrue? So 45% of you have got it correct. That is better visualized in an ilioinguinal approach, and that's obviously false. And I did mention during my talk that when you do a stopper approach, you see it almost every time. And then finally, the question on the Gans surgical dislocation. 41% of you have got the right answer. Avascular necrosis is a common complication. Well, actually, if you read most of the publications by Steven Rock, avascular necrosis, at least in the hands of the right surgeon as an expert, is a very rare complication of the Gans safe surgical dislocation. And that's why it's called a safe surgical dislocation. So well done, all of you. I mean, the majority of you have got it all correct. Over to you, Mike.
Yeah, no, that was great. And thanks. They were pretty challenging questions, and but obviously it's a topic that does come up pretty regularly. So again, thank you so much, Nick and Amol for joining us. Amol and Nicole, for your fantastic talks and all your experience shared with us. What is quite a difficult topic, and we're getting loads of feedback from emails, so we really appreciate all of that. Next week is Alder Hay. They're talking about pediatric orthopedics, and then the week after they're also covering pediatric orthopedics. I'll tweet it sometime early part of this week with the link, and both put it up on their website, and they also tweet it as well, so you'll all be able to register. So we're coming up to 9:30. Enjoy the rest of the evening and the weekend what left, and hope you all have a good week ahead. And thanks again to the speakers, and thanks for Bota for co-hosting it. So good night, everyone.
Good night.
Good night. Bye.